Hello, my name is Juan Kim, and I am an assistant professor in the Department of Neurosurgery at UCLA and co-director of the Stereotactic Radiosurgery and Brain Metastasis program. Today, I'm going to be speaking on neurosurgical techniques at removing tumors. Just a little bit of an overview. Initially, I'll talk about kind of the main overarching tenets of neurosurgical oncology. From there, we'll talk a little bit about image-guided surgical planning, intraoperative neuromonitoring, various radiation techniques, and minimally invasive techniques in order to remove tumors. Now, if I had to summarize really what the major tenets of neurosurgical oncology were, I would say that they are to maximize surgical resection and minimize neurological injury while removing tumors. And especially in the case of brain metastases or tumors that come from elsewhere in the body and travel to the brain, when surgery is indicated, limiting the spread of tumors through spillage of tumors is really, really important. And we'll touch on that a little later, and it'll make a little bit more sense when we get to there. But let's start with the basic principles of neurosurgical oncology: maximizing surgical resection and minimizing neurological injury. The best way that a neurosurgeon can do this is a lot of preoperative planning. I won't go into the indications for surgery or what brings us to surgery, etc. But once a decision is made that surgery should be done and must be done, preoperative planning, deciding how the patient should be positioned, the best approach in order to get to the tumor, all those things and all that preparation is the first and foremost part of an operation. From there, we use neuronavigation, which essentially serves as GPS for the brain while we're in the OR. And then we can use intraoperative monitoring mapping in order to ensure that we're removing the tumor safely, and then use minimally invasive techniques when appropriate. Maximize surgical resection and minimize neurological injury with preoperative planning. So whenever we approach a tumor, we at first look at the structural MRI. Now, the structural MRI, this is an example of a T2 image or an image or sequence of the MRI that looks at fluid very well. It's oriented such that it's slicing a patient like a loaf of bread with the bottom of the head down here and the eyes up here and the frontal lobes right here. Now, when we look at the structural MRI, we essentially have a sense of where all the various anatomical regions are, and we're trying to see what the shortest anatomic corridor is to the tumor so that we violate as little normal brain as possible. Danger zones that we watch out for are certain cortical and white matter structures that we know are important, blood vessels and arteries that can cause strokes if we transgress. And then we can also use diffuser tensor imaging, or DTI, that looks at the white matter tracts that connect cortical areas or brain areas. And by doing this advanced imaging technique, we can see whether or not our corridor might violate these connections. In addition to that, functional MRI is of utmost importance because this helps delineate areas that are important that structural MRI might not show just based on pictures alone, and that have certain interpatient variability. Not all brain is equal. So when we want to see where different areas of the brain that are a little bit less stereotypically represented in people are, for example, language, there's a lot of interpatient variability as far as how language is represented in the brain. So this is an example of a functional MRI where we ask them to perform certain language tasks. And in doing so, you can see different orange areas that light up during this task. And you can see how the tumor is situated in relation to these orange areas. And by doing this, we can have a better sense of where these areas are and avoid them during our surgical resection. Neuronavigation is of utmost importance. Before, we used to make very, very large craniotomies in order to make sure that the whole brain was exposed, and then we would identify the necessary anatomy and then make our decisions where to operate or where to enter based on that. But this allows us to make more tailored craniotomies, so it's just exactly where we want to be. This is achieved through infrared cameras that register the facial features of the patient to the MRI, which includes the face. And by doing so, we can identify structures and where we want to be down to a millimeter of accuracy. The downside is that this is based on preoperative imaging, and so it's not a real-time image. And so we have to make adjustments and know that it can be off the further along we are in the surgery, and then as the brain starts to sink and sag with shifting during the resections. So this is an example of an image where you might think, hey, there's this tumor on the right side of the screen or the left side of the patient's brain, since we're looking up at the patient. This is the back, this is the top. And as such, this might be the best corridor from the surface of the brain to this abnormal looking lesion. However, we did a functional MRI and we saw that there's some speech activation here for speech production. And this was in English. On the right, we saw the speech activation in the patient's primary language, which was French. And so we're like, okay, a lot more areas that we need to avoid in order to get to this tumor. Then we did DTI and saw that there was these white matter tracts that connected production of language to reception or comprehension of language. And then finally, these are motor fibers, motor cortex on the right, and then the descending motor fibers from above on the left. And when you put this all together, you suddenly realize that this is what seemed to be a good corridor initially based on the structural MRI is indeed a minefield of important structures that we need to avoid in order to keep this patient's language and motor function intact. And so you can see how challenging this would be to go through that shortest corridor. So determining a surgical corridor is to take into account all the necessary anatomic structures. And so if you see something like this, you might think, oh, if we go in from the bottom off to the side, it's the shortest corridor, but these yellow fibers are actually the visual fibers. So if we were to transgress through there, this would give the patient a complete field cut or loss of vision on the left half of their world. So we did advanced mapping for this, and you can see that indeed, if we went through the side to the tumor, even though it's the shortest corridor, we would create the most damage to these visual fibers. But if you come from above and behind, then we can avoid all that and potentially remove the tumor with very little damage that way. However, is that enough? And it really isn't, because this is based on structural MRI, but it doesn't give us a perfect map of the brain itself. It's a very good estimate, but as I mentioned before, the brain shifts during surgery, and these fibers, there's a lot of kind of gray fudging that can increase or decrease the accuracy, so it's not perfect. And as such, we have to correlate what we see on the MRI to what we find through electrophysiology and neuromonitoring in the OR. Now, the basics of neuromonitoring, motor evoked potentials is when we send an electrical stimulus through the brain. Now, this could be directly on the brain, or it can be through electrodes that send an arc of current across the skull. And this stimulates the motor cortex, and the appropriate muscles are fired. And so we can stimulate across the brain, and if the muscle contracts, we detect that signal and we know the motor system is still intact. Somatosensory evoked potentials are when we are stimulating the nerves themselves, the sensory nerves, and then we record signals from the brain, and that suggests that the sensory system is still intact. But these systems are assessments of the integrity of the motor and sensory systems themselves. They don't help us prevent injury, they just tell us when injury has happened. So by the time these are affected, it might be too late. EEG or electroencephalography, it detects seizures, which is important to know if a patient's having seizures in the OR that we might not be able to see because they're paralyzed. But I think that the most kind of proactive neuromonitoring modalities that we have are cranial nerve monitoring, where we can not only detect if the nerves are being irritated, but we can stimulate the nerves themselves to see where they are and whether or not we're injuring them. And then electrical stimulation mapping, where we can stimulate not only the motor cortex or the surface of the brain, but we can stimulate language areas during awake surgeries to see if they're truly indeed matching up with the functional MRIs to detect where the language areas are. Subcortical stimulation mapping, where we're stimulating the white matter and the fibers underneath to see if we are getting close to them to avoid damaging them. So we can preemptively or proactively try to hone in on where they might be by varying our stimulation parameters. And then cranial nerve stimulating as above. And it kind of reminds me of this Far Side comic, and it's very much the case. We can actually stimulate different parts of the brain to evoke motor responses. And when a patient is in pins, fixated, with a navigation arm and all the EEG leads, this patient is prone, but this is essentially what it might look like. And this is from a Google image that you can just find online. But this is a diagram which really kind of demonstrates well what it might look like to do the stimulation mapping. So this top diagram A, you can see cranial stimulation, where the signal is being stimulated across the skull itself. Paddle stimulation, where we can stimulate directly on the motor and sensory cortex through a paddle lead. Or we can use a variety of stimulators to stimulate the white matter themselves to see how close we are to the white matter tracks and take our resection maximally up to these areas and prevent damage, because we can reduce the stimulation as we get closer to see how close we are, and therefore really come within millimeters of these sensitive areas without transgressing them. So going back to this example, even though we have a sense of where these sensory fibers and motor fibers might be in this particular tumor, this gives us a good sense of where to enter. But as we get closer and closer to the edge of the tumor, as it gets close to sensory and motor fibers, we need to start doing stimulation mapping. And so in this particular case, that's exactly what we did. And we were able to do subcortical stimulation mapping through that corridor, and then we're able to get a gross total resection and came within 2 to 3 millimeters of the cortical spinal tracts, or the white matters that are responsible for transmitting motor signals by doing this. And this is one of my patients where we performed this, and we were able to achieve a gross total resection in a very delicate location. This is another example where we have a low-grade glioma right within the motor cortex itself. And by doing stimulation mapping of not just the surface of the cortex, so we know where we can enter, the foot area is just medial to this lesion, the hand area is just lateral, and we were able to stimulate around it to find a safe entry point. And in doing so, and stimulating subcortically as well, remove the vast majority of this lesion without affecting the patient's motor function. Finally, in some cases, big open surgeries aren't the way to go, especially in deep-seated lesions or lesions that are deep within the brain. Rather than using traditional methods where we need to pry open the normal brain in order to get there, port-based methods or tubular retractor methods might be a good way to go. So this is an example of a commonly used one where an obturator is placed within a sheath, and using a navigable or a GPS stylet based on the patient's preoperative MRI, we can insert this through crevices within the brain and just push the brain aside. And in doing so, spare a lot of the brain's normal function. And this is really important in cases where the lesion is very close to functional or eloquent areas. And if we did a big open surgery, we might damage the patient's function, or it might not even be possible to do that surgery. So this is a case example of a patient of mine who presented with a very mysterious looking lesion. We thought that this might be a metastasis from a lung cancer or squamous cell cancer, but it just didn't make sense given his cancer history, and it didn't really look like a primary brain tumor. So we opted to go in and take out as much as possible through a tubular retractor system. And you can see here, this is an example of this tubular retractor system. You can see that the craniotomy itself is very, very minimal. It is only 2.5 centimeters. This is a very large vein right here that we are dissecting so that we can place this retractor system within the crevice of the brain and not disrupt the brain itself. Even though this looks like it might be very traumatic, but it in fact is just displacing all the brain tissue through this very, very small opening. We dock on the tumor like that, and you can see this opulescent tumor right here and the normal white matter off to the side. Using a side-cutting minimally invasive device that's flat on the bottom, we're able to debulk the tumor, we're able to remove it and circumferentially dissect it away from the white matter and continually bring the tumor in on itself until you start seeing the normal white matter all around. And this is very, very atraumatic to the normal white matter. And in doing so, we're able to debulk the tumor and remove it in its entirety. And you can see the normal white matter here now. We get hemostasis and then place a collagen sponge in order to prevent any rebleeding. And then you can see that the vein is a little compressed, but very much intact. And by doing this, we're able to get a gross total resection in an area that is close to language, under motor and sensory. And this patient did incredibly well, and we were able to remove the tumor in its entirety. And it actually did end up being a primary brain tumor, and we were able to cure this patient by removing it all. Another important minimally invasive technique is laser interstitial thermal therapy. Now, this is something that has come dramatically more into vogue in the last decade or so. And this is thanks to novel software processing that allows us to perform MR thermography. MRI thermography is essentially where we can translate the movement of water molecules and how they change when we are adding heat via laser fiber in the MRI, and estimate or predict the tissue heat maps or the amount of heat energy brain tissue is getting in real time. This is done through a stereotactically or GPS guided laser fiber. We make a small incision, about 3 millimeters, with a 3 millimeter twist drill hole. And in doing so, we can place laser fibers into deep-seated lesions, into areas where we might not want to do a big surgery because it's eloquent and there are critical structures we want to avoid. Lesions that have failed stereotactic radiosurgery or SRS, and in addition to that, more and more patient preference. Some patients are saying, "Doc, I don't want a big surgery. I want this dealt with minimally invasively as possible. Is laser ablation an option?" This is an example of what one of the system looks like. This arm is one of those stereotactic arms that we use neuronavigation or GPS in order to place the biopsy needle via a pre-planned trajectory that we plan out on an MR planning station. This is the laser fiber. This particular one is cooled with saline. This one over here is cooled with CO2. The one on the right actually has a diffuse laser fiber as well as a side firing beam, which helps you direct the ablation a little bit. And this one also has a robotic arm so that you can insert or pull out the laser as well as rotate it within the MR without ever having to touch the patient. This is a map of an ablation that we performed for what seemed like a radiation failure of a brain metastasis. And you can see how this map shows the thermal damage. This is kind of sped up, but over minutes, this yellow is the necrosis that we are performing or we're delivering to this tissue. And eventually we were able to ablate this lesion in its entirety. And so this patient avoided a large craniotomy in order to remove this. And we were able to control this lesion with just a 3 millimeter incision. Now, I think that one of the most compelling studies for the use of laser ablation just came out last month in April. in neuro-oncology advances. And this particular study was for the laser ablation of glioblastoma. Now, there's been an ongoing multi-center, prospective registry for glioblastoma patients as well as other patients that undergo laser ablation. Now, this includes brain metastasis patients, epilepsy patients, and glioblastoma patients. Now, this study that was published last month was comprised of 14 different institutions that submitted 89 patients. 29 were newly diagnosed, 60 were recurrent GBM patients. All of them were IDH wild type. In addition to that, 5 out of 29 of the new and 23 out of the 60 of the recurrent ones had positive MGMT promoter methylation, which means the majority of them actually were MGMT promoter non-methylated, which we know has a worser prognosis. I think another compelling component of this registry and the data was that it really demonstrated what would happen if you had good technique and good outcomes, as the majority of these patients had more than 90% of their tissue ablated. And as we know from the GBM data, that is an important number as far as conferring a positive prognosis. As far as the demographics go, 52 of these newly diagnosed and 42 of these recurrent patients had lesions that were deemed unresectable, so may not have been candidates for an open surgery, which is huge because these usually would have undergone a biopsy and radiation and then potentially a clinical trial later on, but without significant surgical debulking or what we call cytoreduction or reduction of the tumor cells. And finally, I think that this registry and this publication reflects a lot of real-world practice, because 41 to 42% of these patients chose laser ablation and said, "Doc, this is what I want," irrespective of whether or not that was the best option, and they were allowed that option. Now, this is a paper that was published by Dr. Barnett in Cleveland Clinic, and he has one of the larger series as far as laser ablation for glioblastoma. And you can see in the top left how you have this irregularly enhancing lesion within the thalamus, area that we do operate on, and that GBM I showed you earlier was a thalamic GBM, but it does take advanced mapping. It's a big craniotomy. These patients stay in the hospital for about a week, but this was done with a laser ablation, and you can see the post-ablation scan in the top right. A few months later, you can see continuum involution of this lesion, and then at 12 months, you can see that it's almost gone with restoration of the normal architecture and thalamus, etc. Within this registry that I was talking about, skin-to-skin time for these ablations for these GBMs was about 3.5 to 4 hours, rather than a large craniotomy, which we know can take hours longer. Medium laser time, 25 to 26 minutes. Medium length of stay. So these patients stayed in the hospital for just over 2 days, and 80% of these patients were discharged home. And keep in mind, these are patients where half of them were essentially deemed inoperable. So we know that these are deep-seated, very difficult and challenging lesions. So I think that this is very, very compelling data. But what about survival? Overall survival, if patients had an ablation and it followed with chemo and radiation, was 16 months, which is pretty comparable to the GBM data, which includes a lot of MGMT methylation patients, includes IDH mutant patients. This is slightly worse as far as molecular characteristics go, but they still had a median overall survival that is very comparable to that of GBM patients that receive maximum resection and standard of care. Now, a big take-home point here is that you still have to have the chemo and radiation. So if only one or no adjuvant or postoperative modality, be it chemo or radiation, were pursued, then overall survival was 5 months. So it does suggest that potentially patients with recurrent disease where both options may not be available, overall survival might not be as good. And the same take home with progression-free survival as well. Now, finally, radiosurgery is another minimally invasive technique, and this is very, very, very commonplace and kind of the cornerstone of how we treat brain metastases. But stereotactic radiosurgery is essentially the delivery of highly focused radiation to abnormal areas of the brain. Now, this is not to be confused with laser ablation, even though they sound like they're delivering focused energy in some way. Radiosurgery is ionizing radiation via photons for the most part, which damages DNA. So it doesn't do an instant kill. It damages DNA enough so that cells start to die and then they apoptose or they die through cellular death mechanisms driven by the body. Whereas thermal or laser energy, it burns the tissue, kind of like a surgical technique. So very different and an important distinction to keep in mind. Now, radiosurgery can stop the growth of tumors. In the case of meningiomas or benign tumors, it just stuns them and doesn't make them go away. For the most part, it just prevents them from growing larger. But in brain metastases, for example, it does shrink them and make them go away for the most part. There are many variations of the same concept: gamma knife, cyber knife, LINAC, proton beam. They're all brand names for very similar technologies. At UCLA, we have the linear accelerator and some of the newest models, which we can do very amazing things with. And it's useful when open surgery is not the best option. And a prime example of that is when you have numerous brain metastases, for example. UCLA has really pushed the envelope as far as treating numerous brain metastases. Typically, historically, if you had more than 5 or 10 brain metastases, you got whole brain radiation. Now, whole brain radiation isn't great because we know that if you radiate the whole brain, there are significant neurocognitive deficits that can start happening at 4 to 6 months following the radiation due to the radiation delivered to the hippocampi or the memory structures within the brain. As such, there's been a large push to focus the radiation and do SRS or stereotactic radiosurgery to these individual metastases. Historically, if you had, say, 10 metastases throughout the brain, you could only target 2 to 3 at a time. Each one would require you to pin a frame to the patient and then about an hour-and-a-half session to deliver a single dose of radiation. So if you wanted to treat like 10 metastases, it would take you an hour-and-a-half to 2 hours every day on 3 different sessions, 4 different sessions. Now, with our modern day planning software and our ability to treat multiple mets, we can treat 15, 20 mets all in one session, and it takes 45 minutes. And so with that, we really pushed the envelope and we're really able to treat far more number of mets than we used to. And this is something I'm really proud of that UCLA has been able to kind of push the frontier with. And then finally, limit tumor seeding. This is the second main tenet of neurosurgical oncology. And this kind of shifts our discussion more to the brain metastasis realm. I think a lot of the surgical tenets that I spoke of before still apply in brain mets. So the same thing as neuro navigation, planning with neuroimaging, using advanced mapping techniques, using minimally invasive surgery and laser ablation when necessary. But one thing that in particular that applies to brain metastases is that you really want to limit the spread of tumor cells to the rest of the brain. And the reason why this is important is if you spill tumor cells into the areas where there's cerebral spinal fluid or just even off to the side of the brain, sometimes they can start seeding the cerebral spinal fluid and develop what's called leptomeningeal disease, or disease within the leptomeninges or the covering of the brain. And this can turn a multi-year prognosis into 4 to 6 month prognosis. So it can potentially drastically change the outcome of a patient. So to prevent that, en-bloc resection and neoadjuvant radiation are 2 options. So this is an example of a very large colorectal metastasis in the left frontal lobe. You can see how there's shifting of the brain. There is this gray edema and how it comes fairly close to the surface. It's a solitary brain met. So this patient meets the criteria for surgery. So we offered surgery, and en bloc basically means stay around the outside of the tumor. Don't remove it piecemeal. Don't cut it up on the way out. So you spill as little tumor cell as possible, and then maintain this plane between the tumor and the white matter itself. And in doing so, you limit the risk of leptomeningeal disease. This is an intraoperative video of me removing this tumor after about an hour of work, dissecting all around with these cottonoids, and you can see how by doing so the tumor integrity is preserved, and then we can just plop it out in one giant piece. And then finally, neoadjuvant radiation. Now this is something I want to speak of for the final part of this talk. And I think it's an important one. Neoadjuvant just means before normal sequence. So adjuvant therapy means after an operation, for example, you would give something. Adjuvant chemotherapy, after operation, you give chemotherapy. Adjuvant radiation, postoperative radiation. Neoadjuvant means you do the radiation before. Now, why is this important at helping limit tumor spread? So this is a case, this is a very sad case of a 48-year-old male who had metastatic melanoma to the brain. Now, he had a craniotomy at an outside hospital, which was not the wrong thing, but it was probably a long reach to get here and an open approach. And so there was probably a piecemeal removal of this tumor. 1 month post-op, you can see that there's tumor growing back all along the resection cavity here. And it looks like there might have been violation of the ventricle or the CSF pockets of the brain. 2 months post-op, you can see foci of leptomeningeal disease growing along the surface of the cerebellum. 4 months post-op, you can see caking of the cranial nerves and the cerebellar folia. And this patient, despite maximum medical management and radiation, expired at 6 months because surgery was performed when maybe it wasn't the right thing to do, and maybe it wasn't quite necessary. So how do we prevent something like this from happening? So neoadjuvant radiation, what it allows us to do is treat the tumor before with radiation. So this patient also had what I thought to be a melanoma metastasis, given her history, but this tumor needed to be removed because it's causing obstructive hydrocephalus. We don't know what this tumor is because she never had any Mets before, and it's very, very large, so it likely would fail radiation alone, given its size. So what we opted to do was treat this with radiation preoperatively. We then went in and removed this tumor, and it had to be removed piecemeal given how large it is and in a very critical location of the brain. And by doing the radiation beforehand, we're essentially sterilizing the tumor or killing as many tumor cells as possible, so that even if we were to remove it piecemeal and spill a few tumor cells here and there, ostensibly they would be dead. And so this is her postoperative image after complete resection of this tumor. This is her 6 months out with a little bit of scar tissue there, 2 years out, and still very, very good local control. But unfortunately, she continued having metastatic disease elsewhere in her brain and started failing therapy. But we gave her 2 really, really, really good years because we made the decision to do preoperative radiation, which we're doing more and more of and is becoming more and more popularized throughout the neurosurgical community. So in conclusion, maximum safe resection can be achieved, but it takes a lot of planning and it takes a lot of advanced neuromonitoring techniques. Minimally invasive techniques, they're not just gimmicks. They really can help preserve function, but it's important to know when to use them and to always bring them to the table and ask your oncologist, is this appropriate? Can this be considered? And I think the more we push the envelope, the more that we're going to see that these are extremely useful tools. And especially in the case of brain metastases, complete removal and mitigation of tumor seeding is critical. And I cannot stress that enough. So from the beginning, always get multiple opinions. See people that specialize in brain metastases if this is what you're dealing with or a loved one is dealing with, and make sure that you're not just dealing with one tumor, but you're anticipating the whole entire course of what's to come, because it really is a game of chess and not checkers. So with that, thank you, and appreciate the neuro-oncology group for allowing me to speak on this today.